In this lecture, we will be talking about clinical interviewing and how it functions in the assessment process. To begin, let's talk about what clinical assessment is. When talking about clinical assessment, we're looking at how we measure the signs, symptoms, and pathology we observe in our clients. As counselors, this becomes useful to us because it allows us to gather the information needed to make a diagnosis about our clients. Under current models, diagnoses are made based on observable and client report signs and symptoms. We take this information presented to us and we put it together to form a picture of what may be going on with a client. You could think of the assessment process as putting together a puzzle. Each piece of information or data we receive from a client is another piece of that puzzle. Individually, the pieces may not show us much, but when placed together in the puzzle to create a larger picture, we get a better understanding of what's going on with our clients, what we need to do to help them change, and where they may need to go in the future. In general, we could look at clinical assessment serving three main purposes. First, it's used to guide the diagnostic process. Assessment gathers the information we need to diagnose clients and their issues. It helps us to put a name or a face to what it is that the problem they're having is. Once we're able to label the issue, we can then move to treating that issue. Assessment becomes useful during the treatment process because it allows us to identify techniques or interventions that may be most helpful for a client given their presenting concerns. And finally, we see clinical assessment benefiting us when it comes time to evaluate. Assessment allows us to determine treatment outcomes. Was a client able to successfully meet their goals? Did change occur? Assessing outcomes allows us to plan better in the future and have a better sense of what works and what may not. Despite the many benefits of clinical assessment, there are some cautionary notes to keep in mind. For one, we must be aware of the hypothesis confirmation bias. The hypothesis confirmation bias states that individuals, in this case counselors, may form premature or preliminary ideas about a client and what their problem may be. This may occur based on first impressions, what we read in case notes, should this person have seen another counselor before, or what we may get from an intake questionnaire. This premature hypothesis we have becomes our dominant lens through which we view the client. Because this is what we think is going on, we typically look for information that confirms or validates our initial impression. The hypothesis confirmation bias therefore motivates counselor behavior. Counselors need to be aware of its existence and make sure that they are objectively looking at all the information presented, not just the information that supports what they may believe. A second caution is to be cognizant of self-fulfilling prophecies. These motivate client behaviors. When clients become labeled, there is a tendency to live to the label. Their behaviors and actions will more closely resemble those associated with the disorder they're said to have. As clinicians, we need to be aware and fully assess to see if what we're seeing actually is an occurring phenomenon, or is it just a symptom of the client learning they've been diagnosed with a particular disorder. So as we employ clinical assessment and clinical interviewing techniques in our counseling practice, we do so from different theoretical models or lenses. One such approach is the clinical judgment model. This model is more individual in nature. It's developed uniquely by the clinician. It states that counselors form their clinical hypotheses or judgments based on a unique collection of experiences and knowledge. Counselors use their knowledge of theory, information they gain from the clients or other sources, family, friends, teachers, coworkers, and they combine that information with past experiences, those that they may have had professionally in a clinical setting, and also those in their personal lives. The collection of all of this information allows individuals to make some type of hypothesis about what's going on, what may be causing the client's presenting issues. Because the clinical judgment model is unique to the individual, it has very poor reliability, and it's difficult to replicate by others. The backgrounds and experiences you have will be different than mine. Therefore, if we both observe and assess the same client, we will do so from different points of view, in different contextual lenses. Because of the subjectivity involved with the clinical judgment model, it's not the preferred method of diagnosing or assessing individuals. A more stable and consistent approach would be to use the statistical decision-making model. It's much more reliable and accurate. The statistical decision-making model bases clinical decisions and hypotheses on observable phenomena. using standard criteria for each of the mental disorders, screening instruments can be used to determine what signs and symptoms clients have and do not have, and the degree of severity of those signs and symptoms. For the various screening instruments, cutoff scores are established to differentiate between those whose signs and symptoms are enough to warrant a diagnosis versus those who may not meet full criteria for a disorder. To assist with the accuracy of the information received, several sources of data should be utilized. Client self-report should be but only one of the ways that you collect information about what really is going on in a client's life. As we consider clinical interviewing as an assessment technique, we could roughly divide interviews up into three different categories: unstructured, structured, and semi-structured interviews. Which of these categories a particular interview falls under depends on its presence or lack thereof of certain characteristics. Some of the characteristics of interviews are as follows. Does the interview focus more on content or process? Is it more designed to look at what is going on with the client, the content, or is it more geared towards the process? Why is this going on? One just looks at facts, the other looks at context. A second characteristic is whether or not the interview is designed with a goal orientation or to be more expressive in nature. Are we structuring this interview to be able to establish goals that will guide our future work with the client? Or is the purpose, in fact, to let the client be expressive and simply state their story and share their information? How directive is the interview? Are there specific directive questions that are asked? Or is it more casual, allowing clients to fill in the blanks? We could look at the structure, whether it is a structured or unstructured interview. Is there a standardized admission protocol? And lastly, we could look at the amount of activity expressed by the participants. Is it a verbal exchange? Is it a questionnaire that's filled out? As the counselor, is your role to simply ask questions and record answers? Or are you encouraged to engage clients in dialogue and conversation? So these different characteristics will help us identify the type of interview we may be using. And there are situations that definitely warrant the use of all of these. The first type of interview we'll look at is the unstructured interview. With unstructured interviews, there is no standardized format. Theoretically, no two interviews would look alike. The questions used in an unstructured interview are not predetermined. They're chosen by the interaction between the client and the counselor. Questions derive from responses clients give. And the direction that the interview takes is never really known before it begins. The benefit of these types of interviews is that they allow clients and counselors to develop rapport much more quickly. The mechanical aspect is replaced by the humanistic component. In an unstructured format, counseling resembles more of a conversation. And it allows for a more realistic exchange of information between two individuals. If placed on a continuum, structured interviews would be the exact opposite. These are interviews that have established question protocols that are applicable to and asked of all clients. Every client is asked the same set of questions in the same order. The administration process is standardized for these. There is no room for variation on the part of the counselor. The user manuals are very prescriptive for these types of tests. These are mainly used for diagnostic purposes, whereas an unstructured interview may allow clients to be more expressive. With a structured interview, we're more focused on gaining the facts, and the facts that will be used to make the decisions we need to make in terms of level of care, goals to set for treatment, and services that may be needed. Structured interviews also allow us to make diagnostic decisions, and they usually align with the DSM criteria. An example of a structured interview would be the SCID surveys that you could use, the Structured Clinical Diagnostic Inventories. These interviews include specific questions which should be asked to evaluate the presence or lack thereof of signs or symptoms relevant to a particular disorder. Clinicians can then evaluate the information received and determine whether or not an individual meets criteria for a disorder. Somewhere in the middle of these two, we have semi-structured interviews. A semi-structured interview captures elements of both the structured and unstructured interview. There is a set protocol that's used for questions to be asked. However, clinicians are allowed to improvise and change up. There may also be a sequencing chain of questions that's activated based on client responses. For example, an interview may have a structured protocol for a suicide assessment. That should a client indicate thoughts of potential harm to self, there's a series of questions that are asked related to intent, access to means, support systems, and such. However, if when interviewing a client, they deny any suicidal ideation, and there is no reason to believe this is a concern, we may skip those questions because they're not relevant to this particular client. So semi-structured interviews provide you the freedom to go off script and change as situations warrant. In a clinical setting, you may also use an intake interview. Intake interviews are useful for gaining a great deal of information about your client. In the beginning of the counseling relationship, it's important to gather as much information about the client as possible. The more information we have, the better able we're to make treatment decisions that are beneficial to the client. Intake interviews typically take place during the first session or two. However, in some situations, it may even occur prior to the first meeting. Some agencies or mental health centers send questionnaires home to potential clients, and they're asked to complete these questionnaires and bring them with them to their first session. The benefit of such an approach is that it allows for more interaction with the client during those critical first few sessions where rapport is built and the decision of whether or not to come back is made by the client. Within the intake interview, there are several different components that are assessed. Demographic information could be collected. Reasons for referral, the current situation. What is it that's bringing you in for counseling right now? Any previous experiences with counseling, and that could include therapy, psychiatric treatment, inpatient, outpatient care. Any issues of birth or developmental history that may influence current behavior or thoughts. Family history, including family medical and psychiatric mental health history. Medical history of the client. And any educational or vocational background, including military experience or training. While much of this information may not be relevant or may not even be used by you in a clinical setting, having it on hand is never harmful. You really can't predict down the road what information you may need and how an inconspicuous piece of information now may actually be very useful and a key to future treatment decision. If you work at an agency or mental health setting, chances are that agency has a standardized intake interview or assessment screener that they use. If you intend to work in a private practice on your own, you'll need to create your own intake interview. An example of an intake interview can be found on the Blackboard page for this course. Another type of clinical interview is the mental status exam. And this is one of the instruments you're completing for your class requirements. The mental status exam is a quick way to screen for clients' intellectual, emotional, and neurological functioning. It's typically used to determine whether or not clients are able to make informed decisions on their behalf. A mental status exam is typically administered in the first couple of sessions, but it also can be used after a significant change in cognitive functioning. It's not an instrument that would be used every session. There are several different types of mental status exams, but they all comprise similar content. Status exams, we see 6 different content areas covered. There will be an opportunity to assess appearance, attitude, and behaviors, cognitive abilities, any speech or language deficit, any disturbances in thought, content, or process. There will be an opportunity to assess for current emotional status, as well as clients' insight and judgment into the current problem or situation. Scoring is then based on how many areas are completed successfully. Depending on the version of the mental status exam you're using, points are awarded for how well a client responds to a question. There could be full credit, partial credit, or no credit assigned. Cutoff scores are then used for the total score to determine whether or not this person has any cognitive impairment that may alter or hinder their judgment. Additional clinical interviewing assessment techniques include checklists and rating scales. A checklist is a simple, easy-to-use way of gathering information from a client. A list of signs, symptoms, behaviors, or thoughts are presented to the client, and they're asked to simply check off whether or not that one is related to or pertinent to their situation. With a checklist, it's typically a dichotomous response that is sought. Either you as a client have this or do not. When we look to expand the context and look at magnitude or degree, we're really talking about rating scales. Now clients could not only say, this is a symptom I'm having, but they could give a degree of severity as well. So rating scales may be helpful in determining how pervasive the problem may be for the client. Regardless of the assessment approach you take, clinical assessment is designed to allow you to make diagnoses. And the diagnoses we made are based on the DSM, the Diagnostic and Statistical Manual. And as you're probably aware, a new version of the DSM, DSM-5, was released just last month. Under the old version of the DSM, we made clinical decisions by evaluating clients on a multi-axial system. There were 5 different axes on which we assessed clients. The first was any clinical disorder or condition noted in the client. The exception being personality disorders or mental retardation, which were coded on axis 2. The reason for the separation between these 2 axes was the transient state of disorders. The more pervasive, long-standing disorders were coded on axis 2, whereas more temporary states were coded on axis 1. On axis 3, we listed all of the current medical conditions a client was experiencing. Axis 4 included psychosocial and environmental problems. These were issues in the client's life, either good or bad, that may be compounding or contributing to their current mental health concerns. And then finally, on axis 5, we had the global assessment of functioning. The GAF score, as it was called, was a rating on a scale of 1 to 100 in which clinicians rated the level of functioning of the client. The GAF score was very subjective and left a lot up to clinicians' interpretation of client presentation. And so the reliability of GAF scores was never very high. But all this is changing. The new DSM looks at diagnosing clients in a different manner. Using the new DSM-5, the multi-axial system has been dropped. Axis 1 through 3 are all collapsed into a singular axis. All mental health and medical issues are now coded on the same line. This is similar to how diagnoses are made using the ICD, the International Classification of Diseases Manual. This is the manual that physicians and doctors use. If you review the DSM-5, you'll note that the diagnostic codes align with the ICD codes, as there's a movement to try to mainstream or connect these 2 manuals more closely. With this new collapsed singular axis, there's going to be a need for new ways to diagnose or collect information about clients. One example may be the ICF checklist. It could be used to identify signs and symptoms and make clinical decisions related to diagnoses. The ICF checklist is a lengthy questionnaire to use with clients. It's 15 pages in length, and a copy of it is placed on the Blackboard page for you to view. The other two remaining axes, axis 4 and 5, are being dropped altogether. In their place, clinicians will be asked to give specifiers to the disorders that they diagnose. These specifiers will be able to denote severity, as well as account for any relevant contextual or situational factors that may be playing a contributing role to the continued presence of that disorder. In summary, as we talk about clinical assessment interviewing, some considerations for some pitfalls to avoid to ensure that your assessment is valid and helpful to the counseling process. You should avoid falling victim to the nice guy syndrome. Sometimes when we assess clients, we have a tendency, it's a human characteristic, to be nice to the individual and not note every one of their problems and faults. Keep in mind, however, that our goal is to help them in the long run overcome these problems. And so we need to get an accurate picture of what's going on. You should avoid being collusive or aloof. The more mysterious or vague you are, the less trust the client will have in the assessment process. The more upfront you are, the more they'll understand the benefit of the process, and the more participant they'll be. You want to avoid being a technician. Losing the human element completely and becoming robotic damages rapport, and the connection and trust with a client is not there. We need to avoid being a rescuer. Our goal should not be to throw the life raft to our clients or put a Band-Aid on their problems. Rather, it should be to teach them how to swim or teach them how to solve their own problems in the future. And finally, avoid being an opponent. In the counseling relationship, there should be collaboration. Counselor and client should be working together on the same side. And lastly, be culturally sensitive in your interviews. You should be aware of your own cultural background and experiences. While we're trained and taught as counselors to leave our values at the door, in reality, that's very difficult to do. Rather than leaving them at the door, what we need to do is learn how to manage them and not allow them to interfere interfere with our clinical decision making. We need to educate ourselves about the different ethnic groups or cultures or diverse groups with whom we're going to work. The more knowledge we have or understanding of a particular group, the more likely it is that we'll understand what it is we see in our clients and be able to determine what would be considered normal and abnormal in that contextual environment. And finally, we need to be able to modify our communication style. With different clients from different backgrounds, how we communicate the information we share, the degree of structure we have in our interviews may need to change. For some, a more formal, structured process is beneficial, whereas for others, a less formal, more conversational, humanistic approach is preferred. And so the key is matching what it is you do with what is going to be most beneficial for the client.